Thank you for the presentation. It's quite interesting kind of piece of work, especially putting things together. Now, FDG came relatively, but it was early in the research part of evaluation of the CNS. But in nuclear medicine, we had HMPO, we had, like the normal or the conventional cerebral perfusion imaging, and from that there was a lot of indications as to patterns of abnormality. Would these still be kind of useful in this day and age to, be part of the evaluation of the, especially dementia?
So a good question. If I understand correctly, your question is the role of brain perfusion imaging in the assessment of suspected dementia or classifying dementia. The same characteristics we see with FDG PET should be seen in perfusion SPECT with HMPAO, ECD, or even iodoamphetamine in older days. But the technology underlying PET allows a much statistically more robust depiction of areas of the brain that are functioning normally versus those that are not. So I think just from an image characteristic, we favor FDG PET over perfusion imaging, but the same principles should apply.
Yes, thank you. We had our experience is the same with the perfusion SPECT scan. It fairly mimics the oxygen, the glucose metabolism.
Yeah.
One more question. Can I have a quick question before you do? You said about the amyloid imaging that they precede by 20 years the changes clinically, and does treatment, can treatment then alter the course of the disease? And if so, how?
So that is, of course, the very critical question that we'd all like to have the answer to. What we know is that the pharmaceutical industry has been targeting approaches to stop or even remove amyloid. But what we know also is that if we wait until the patients are symptomatic, let alone demented, the existing approaches do not have a clinical benefit. So one of the first trials, the Elan pharmaceutical trial to immunize against amyloid, did not result in any patient improvement. But at autopsy, the amyloid had been removed from the brain in virtually all the patients that were investigated. So there was an effective anti-amyloid treatment that had no clinical benefit. So the idea now is if we're still thinking that amyloid is a good target, we really need to attack it before symptoms of neurodegeneration develop, and that means we need some way of knowing who has it. So I think the imaging will be critical to that, and the only way to test whether this works is to combine PET imaging for amyloid with the application of these anti-amyloid approaches. So I think that's what we're looking forward to in the next several years, and hopefully we'll have a favorable outcome.
Okay, just a short question. A person like me who has more experience in HMPO perfusion scans, I always thought that the Parkinson's or the Alzheimer's disease, I was looking for defects in the parietotemporal region rather than in the frontal lobe region. And your scans of amyloid is showing a lot of uptake in the frontal lobe lesion. And this is what confuses me now. You get my point?
No, very good. And your observation is exactly correct. So what this tells us, I think, is that the pathology of amyloid is not what's being imaged by FDG, and it's not showing us the pattern of neurofibrillary neuronal degeneration. So these pathologies are together in the same brain, but they're not even necessarily in the same areas involving necessarily the same cells. Remember, the amyloid is extracellular. It's an accumulation outside of the cells in the synaptic neuropil area, whereas the neurofibrillary degeneration is intraneuronal and I think signals a nerve cell that is dead or dying. So that's exactly right, and the relationship then between how amyloid present in the brain for maybe more than 10 years triggers a different degenerative process that now involves nerve cells is a complete mystery. We know that the two together are required for the pathologist to say the diagnosis was Alzheimer's disease, but how the amyloid deposition triggers neural degeneration and neurofibrillary tangle pathology has not been explained. And you're right, they're completely separate processes except that they're in the same brain.
Okay, thank you very much for this brilliant insight.